But why sudden unexpected death in the context of the genomic medicine service? We understand about sudden unexplained death in terms of, we know a definition, a witnessed spontaneous death within an hour of onset of symptoms, or an unwitnessed death seen alive in the previous 24 hours. And we also know that in terms of cardiac causes, the majority of those are very sadly due to underlying ischemic heart disease, coronary artery disease. And to my mind, it is unimaginable to know how families cope with that very, very sudden loss of a family member, often a young adult. But it must be even more unimaginable if there is no clear explanation for that death, or if that death also signifies increased risk to other family members. So this is why it is starting to fit within the remit of the genomic medicine service now. And partly that is because for those unexplained deaths, we know that a significant proportion of them have an underlying genetic cause. So when there is some structural abnormalities at the heart, such as heart muscle disease, cardiomyopathies, for example, we know that post-mortem testing in the research environment yields a very significant rate of diagnoses. So really, I want to sort of start the rest of the talk by just putting into context the potential benefits of this. And this is an anonymized family that they have given their permission for use, that has come from Professor Elijah Baer's clinic in South London. And Elijah is the overall principal investigator around this particular project. And this was very sadly based around the sudden death of a young girl who was woken up in the morning by her alarm and was then found dead. And that sort of sudden loud sound trigger is very well recognized in a group of inherited cardiac arrhythmias called long QT syndrome. But fortunately, the family were willing to take part in a research program. A DNA sample was obtained after a normal autopsy. And in terms of research testing, the underlying genetic cause of the suspected diagnosis of long QT syndrome was identified. But you can spot that there was a sister, and she had already presented with a history of collapsing syncope in response to the doorbell. And it was then went on to be shown that she also had the same variant, confirming a diagnosis of long QT syndrome, and she was placed on medical therapy. Unfortunately, she didn't fully respond to medical therapy, and then went on to have an implantable defibrillator fitted. And since that was fitted, it has now discharged a total of 3 times. So I think there's very, very clear and obvious benefit to how this type of testing can impact very, very dramatically on families. And of course, we've spoken about 2 daughters. There's also the issue about which one of the parents and potentially other family members are at risk. So in terms of how this has all been played out, I'm just going to go through this in a fairly high level. This was a complex system to set up. So you can see that we've gone all the way through from identifying the key stakeholders in the pilot sites, really starting to work towards how we can understand the legal framework around tissue consent, tissue retention and consent, making sure that those families are then signposted into the NHS. The coronial service is not within the NHS, so they don't use the same systems. Signposted in, how the coroner's office who are conducting this work can be adequately trained in this area, and that there is also access to expert cardiac pathology. A lot of that in this country has been funded by CRI, funded by a charity. It's not embedded within the NHS. And making sure the key people to facilitate this whole pathway, the ICC coordinators, are in post. And all of that has now been achieved across all of the 7 GLH sites. We've also got external evaluators in looking at this programme of work, as well as health economists as well. And in addition to that, the Royal College of Pathologists is looking at great detail about establishing a specialist cardiac pathology service. And this is our toolkit. I'm not going to go through all of this in detail, but it's been an enormous amount of work pulled together by the BHF and other individuals about providing that framework that we can just use to go out and support the service across the country. One key part of that is the generation of very high quality information for families, for example, and again, cardiac risk in the young have been essential in co-developing all of this work, and having this information, especially from the coroner's officer perspective, is an important way of establishing contact with families. And we've also heard Sue Hill talking about the test directory. In terms of the test directory, we now have genomic testing for the sudden unexplained death survivors now embedded, and a test that can now be formally requested through the Inherited Cardiac Conditions Clinic. And so a very high-level summary of where we're up to now. We've certainly made huge progress in breaking down silos, in particular establishing communication and pathways between the coronial service and the NHS Inherited Cardiac Clinics, increasing access to those clinics so families are now routinely signposted in. We don't necessarily have to follow traditional referral pathways. They can be signposted straight in, and a lot of that side of things can be followed up afterwards. And also acting as a catalyst for change, driving the revision of the Inherited Cardiac Conditions Service specification and starting to participate with the Royal College of Pathologists, as I've said, in designing a specialist cardiac pathology service. Where are we up to now? Just in these first year, in the first few months, what you can see here is that we are now getting families flowing through this pathway cumulatively across the NHS. We've had about 40 families coming through, and that's resulted in nearly 200 at-risk family members being identified, and at least 80 of those are now going through those pathways and potentially not only being screened, but being offered genomic testing if appropriate. And of course, all of that needs to be used as a framework to start thinking about national rollout, because clearly what we're hoping is that the evidence will support this as a national service. Our focus still remains on the delivery of the pilot to generate the evidence. However, we have been tasked with thinking about that national rollout, and we're working together in the East GMSA and the North West GMSA to scope that out in more detail.